Welcome to this Philips symposium. My goal is to explain you the role of cone beam CT in prostatic artery embolization, specifically with the new offer that I recently was able to try in my angio room in Paris. But before, I'd like to remind you, for those who have no experience or little experience, what is cone beam CT? Cone beam CT is basically making CT-like image in the angio room using a 240 degrees rotation of the C-arm during intraarterial injection. So what can I get out from it? It allows to produce 3D display of arterial anatomy using MIP or volume rendering or vessel tracking. It produces also CT-like slices and volume, which will help you to assess soft tissue, whether it's for perfusion or for understanding of the anatomy. And it can be combined with other imaging, doing what we call fusion imaging with MRCT or echography. Why do I need cone beam before embolization in prostatic artery embolization? Because I need to find my way to the prostate. What are the feeders? Where is the ostium? What is the best projection for catheterization? And being able to do this as fast as possible using fusion or some type of vessel tracking in some cases. During embolization, it's very useful to see where the contrast and the particles will go. Will it target the whole prostate volume or the whole prostate lobe? And will it create a risk of non-target embolization? So challenge in cone beam CT that we know and we have been facing since several years in the previous setup of the room was the injection protocol, the need for appropriate and easy patient C-arm positioning, and also problems related to training of the IR and the techs. So what I need, in fact, when I do prostatic artery embolization and when I do PAE is an easy and reliable workflow. I need no hurdle in my workflow, and I need that all team members are at ease with it. And I need also something which allows me to reduce contrast injection and reduce radiation to the patient and staff. So the case that I'm going to share with you today is a 70-year-old man with nocturia, IPSS of 33, quality of life of 6, PSA of 5. His volume of prostate is 77 ml, and he doesn't respond to alpha blockers. And he doesn't want surgery because he wants to keep good sexual function. So I'm going to show you the MR of this patient. You can see on sagittal imaging, we're seeing a large prostate here under the bladder. We are going to axial projection. There is a large left lobe which is protruding into the bladder. The bladder is not so diseased, a little thin wall. And you can see a very large adenoma with compression of the peripheral zone. This is quite usual when we do PAE and we look at the MR, and we always do MR before embolization. So we go for femoral artery puncture. We use radial or femoral. Here is a case of femoral artery puncture. And we would directly, after insertion of the sheath, we would directly go for global cone beam at the aortic bifurcation. And now with the new room and the new setup, we can do rotation in 5 seconds on the lateral projection, which is very useful. And I can pilot everything from the table, the side table monitor, as you can see. I can play with the screen, even with this protecting plastic film for preservation of hygienic reasons and no microbial contamination. So this is the 3D cone beam, which is the creation of the images while I'm injecting at the aortic bifurcation. Everything is very user-friendly and very fast. Reconstruction would be right away without waiting for more than 1 second. And then I can see the axial images and I can play. You can see with my finger without to be deserialized. I don't need to go to the control room. I can play with projection. I can go lateral, axial. I can go for MIP projection. I can go for VRT analysis of the volume, everything like that, which will help me to drive my strategy. So this is here trying to change the layout of the presentation. You can see here, this is an MIP projection. I'm trying to map the prostatic artery. The prostate is here. I see two big feeders on the left, which are going together. They are from one single artery. So I'm putting a pointer here with my finger. You can see the pointer, which will go with under my direction into the prostatic artery. So this is a distal point. And then I will go up, scrolling the images up, and then point another vessel, which is a vessel in the inflow side branch of the internal iliac artery. And then it will automatically display the trajectory of the artery. So I know very well where is the prostatic artery, how it looks, where I need to go, and what is the appropriate projection of the C-arm. So I can now play with the 3D volume. This is the blue line is my prostatic artery, which is arising here from the obturator, which is not uncommon. This is not the most common presentation, but this is what we see often. And here I can just choose exactly what is the best projection to do catheterization, and you will see that I can mix this image with the fluoro and help me to do the catheterization super selectively in a very, very efficient and time-efficient approach. Trying to rotate the C-arm and see what is the best magnification that I can get. You see I'm moving now my guiding catheter, my 5 French internal catheter going to the internal iliac artery, pushing the wire a little deeper, pushing the catheter, the diagnostic catheter a little deeper, and then do a very quick angio run to check that I'm in good place. Here we go. So I go for an angio with the automatic injector, and you can see that I see the prostatic artery here, which is small on this big screen, but it's a relatively large artery. I can mag it, and I can use this fusion to catheterize with my microcatheter the ostium of the left prostatic artery. Now I'm playing and changing the wires, the curve of the wire, going to selectively inject the left prostatic artery. And you will see, interestingly, that this artery is not so easy to access because there is a big rectal branch, which was a question on how to manage, and I will try to share this with you in a few seconds. You see now I'm trying to access the prostatic artery, so now it's more a problem of catheterization than of imaging and guidance. Now I am in the left prostatic artery, and you can see that there is a big artery going to the central part, median part, upper part, which we call the cranial prostatic artery, and there is another one which is in fact more of a rectal branch going distal here that I want to avoid. So what I will do now is that I will push my wire further into this branch looking like a corkscrew, which is very typical of the prostatic artery. And the other here, which is a little more faint, is the rectal branch. So now I am selective, super selective in the prostatic artery. I'm doing a cone beam. You see I'm checking for the cone beam. These yellow rectangles are allowed to really point and focus on the zone of interest. Programming, 5-second delay, injection with the microcatheter in the left prostatic lobe to check whether there is an anastomosis. And in fact, in this case, there was an anastomosis, which was something that we didn't want to embolize. So this is a cone beam CT selective in the left lobe. And you can see here scrolling rapidly on the 3-axis projection that you have some uptake of the basis of the corpus cavernosum and left side of the corpus cavernosum. And when we do the embolization on the next run, you will see that there is a very little branch that is going there that we don't want to embolize. So in this situation, we take 300 to 500 microparticles. We don't take 100 to 300 because this is more dangerous. And you will see on fluoro, here again, playing with the cone beam that I've done entirely on my own. The tech just need to connect to the microcatheter. You can see here that I'm using the roadmap, negative roadmap, which is generally what we use when we do glue injection. And I'm trying to show here that there is no flow going to the basis of the corpus cavernosum. So I'm completely controlling everything that I'm doing. Now I'm doing perfected technique after completion of the embolization, ready for perfected technique. You see that there is still some branches feeding the left lobe. And now I'm going to the right lobe, which is a type 1 quite difficult. You can see here playing with the post-processing station at the table side that there is a type 1, which is in fact, you see after tracing the vessel, which is not so easy to unmask, so it was very useful. And in this case, because the artery was really going back and up and back on the right and on the left, I had to use a Ninja microcatheter, and you can see here how bending the curve of the Ninja was very useful. This is my wire going into the left prostatic artery. Now I'm doing the pre-embolisation opacification of the right lobe. If you remember, the right lobe is much smaller than the left lobe, and there is also this big anastomosis here, which is a dangerous one. I cannot coil it here because of the very small size of the intraprostatic anastomosis, so I use the same artifact that on the left side, which is specific negative roadmap. So as you can see, and these are my take-home points for this presentation, cone beam is really very important for PE. I don't know how we can do prostatic artery embolization without having a room with a cone beam CT. We need a fast and reliable workflow. Otherwise, you cannot really manage, you cannot use it. And I think we have a lot to discover more in terms of clinical validation. So now I'm ready for question and answer if needed. Thank you.
Thank you, Marc. Most impressive, and maybe even more impressive, at least to me, is that you managed to do your own SmartCT and all of this stuff by yourself. And I think you said you've only had the system for a week or 2 weeks, something like this?
Well, actually, this prostate was my first case.
Amazing.
but to confess, your staff was in the room, so they helped me a lot.
But how, so since you brought it up, what is your learning curve like? The system should just feel like an extension of our hands. How has the learning curve been for you with this?
Very, very fast. I don't think I'm 100% at the top level, but I think I'm already at maybe 70 or 80%. I can do most of the things I'd like to do. The only thing I've not tried yet, and I really anticipate trying that, is to import fusion imaging with, as we discussed off the record during the video, for pre-op MR of the prostate or of fibroids or whatever, or liver, to see how you can integrate this in the new workflow. I think it's, for me, it's the next step, but I can tell you I have cases scheduled next week, and I will focus on that.
And you are also doing, of course, more than prostate. So you brought up fibroids. Are you doing SmartCT for other applications as well?
So in our short experience, we've done a few peripheral vascular arteries. And well, to be honest, I don't have enough experience to really discuss this today. We've done 2 or 3 liver intervention. One was very exciting, which was preparation for intra-arterial catheter delivery, you know, when we put arterial ports. And then there is always a big challenge finding the right gastric and left gastric, because it's a very small and very difficult artery to catch, because there are really crazy angles, with angles like 180 degrees back, something like that. And it was very helpful to find out and unmask it and find the appropriate projection.
Yeah. We have a couple of, one comment and one question from the audience, and maybe I'll ask the panel. First, the comment, which I like. Thank you, Rick, for your talk. And also, you win the award for the most stunning background scenery. And they wanted to know where it was from. And then the question for everybody is, now that you can do these cone beam CTs and 3D acquisitions in the room, are you staying in the room, or do you leave the room during that spin?
Well, we always leave the room. Even with the COVID patients, we managed to have a special space which is closed. We can go and be secure, don't have any X-ray exposure, but we don't go into the control room and be in contact with other person of the staff. But we always go outside. All the management, we do it at table side near the patient, so we can talk with the patient and he don't feel like being left alone for 10 minutes. So, but for the acquisition of X-ray, we always leave the room.
Yeah. Okay.
So we would step back something like 3 meters. We would not go out from the room. We would not go in the control room because it's too small and we would have some sterility issues. But for sure, we step back. The only time where we don't step back, and I know there is controversy on that, is when we do super selective intra-arterial injection in the prostatic artery, like I showed on the video. Usually we do it manually, but we can also, so if you do it manually, you have to stay close to the C-arm. But what we can do is doing with automatic injector, or some people are also doing automatic injection and then they just do it after embolization, not during embolization. So this is another approach. But I know that Isham did some work on the radiation load from the cone beam, which apparently is not so high as we fear it is.
Because it's rotational, you don't have like a special region, special area will be exposed to X-ray. But we have a large control room, and so we can manage to go out in our settings. So we need at least to be at 3 meters from the X-ray tube. It's really, really important to do this. Even if you are doing manually, you need to really, if you have long catheters and long micro catheters, you need to really stand very, very far from the tube.
Yeah. Well, I think our time is up. So thank you very much, Marc. And thank you to all of our terrific speakers. I think this was a really fantastic session. So again, many thanks to our fantastic speakers. And I know I will see you all in person in Lisbon next September at CIRSE 2021. Enjoy the rest of the Congress.
Thank you.
Thank you, and stay safe.